everyone, my name is Brianni Whitehead and I am a member of EBP group number 9, and the PICO question we formalized is: for hospitalized geriatric patients at risk for falls, does the use of video monitoring compared with hourly rounding and bed alarms alone impact the number of hospital-related falls and injuries throughout the hospital stay? So some background. Falls are a significant patient safety concern in hospitals, with approximately 700,000 to 1 million patients experiencing falls each year. About 250,000 of these falls result in injuries. Geriatric patients are especially vulnerable because of factors such as poor vision, medication effects, and balance problems. Hospitals use interventions such as hourly rounding and bed alarms to reduce fall risk, but falls can still occur. This is what led us to explore continuous video monitoring as an additional fall prevention strategy. The purpose of our project was to determine whether video monitoring could replace falls and fall-related injuries among hospitalized geriatric patients at risk for falls. The population behind our PICO question was geriatric patients at risk for falls. Interventions include video monitoring, including continuous, overnight, and two-way monitoring. Our comparator was bed alarms and hourly rounding. Our outcome was reduction in falls and fall-related injuries, and our time frame was duration of the acute care hospitalization.
Hello, this is Jasmine. For our evidence collection methods, we conducted a literature search using PubMed and CIN-AHL. We used search terms related to our PICO question, including video monitoring, video surveillance, virtual sitter, remote monitoring, patient falls, fall prevention, and inpatient falls. We also used the Boolean operators and/or to help narrow and refine our results. Our search initially produced more than 1,006 articles. We then applied filters to focus on our primary research published within the past 15 years, with a preference for studies published within the last 5 years. The remaining studies were appraised based on their relevance to our PICO question, study design, and grade quality, along with instructor and peer review. After completing this process, we selected 5 primary quantitative studies that provided the strongest and most relevant evidence for our project.
Hello, this is Marian, and I will be going over the first part of our results. Our results pulled statistics from prospective and retrospective cohort studies and quasi-experimental designs that were conducted across diverse healthcare settings in Australia, Canada, and the United States. Across all 5 studies, we found that video monitoring was associated with a significant reduction in patient falls amongst hospitalized patients at high risk for falls. This population included older adults who were considered at high risk for falls, including populations in acute care, long-term care, and specialized geriatric units, individuals with impulsive behaviors and a lack of insight into their limitations, those at risk for harming themselves by pulling on lines, tubes, or airways, those on essential medical devices, those with reduced alertness, individuals with cognitive impairment, or individuals with brain injuries. While these results provide valuable observational insight, the strength of the evidence carries a low to moderate certainty due to the selection bias, self-report of staff outcomes, and the lack of a comparative control group. The first key outcome. In their prospective observational cohort study, the researchers identified a group of patients receiving continuous video monitoring and followed them forward in time over a 20-month period to measure outcomes, which were the measurement of monthly fall rates. They observed results as they naturally occurred without randomly assigning patients to interventions versus control groups. Inpatient falls decreased by 25.1%, and fall rates per 1,000 patients significantly decreased from 4.9 to 3.8%.
Hi, my name is Daniel, and for our second study, the researchers used a prospective observational cohort design. They identified patients receiving continuous video monitoring and followed them forward over a 20-month period to observe fall outcomes. Because the researchers observed outcomes without randomly assigning patients to groups, this was an observational cohort study. Inpatient falls decreased by 25.1%, and the fall rate decreased from 4.9 to 3.8 per 1,000 patient days. The third study was a retrospective historically controlled cohort study. Researchers looked back at existing hospital data and compared patients from before video monitoring was implemented to patients after implementation. Fall rates decreased from 3.5% to 2.7%, and the post-video monitoring group had a 51% reduction in the odds of falling. The next study used a prospective cohort design because the researchers followed high-risk patients across 3 inpatient units forward in time during portable video monitoring. Overnight falls significantly decreased from 56 to 25, and the overnight fall rate decreased from 4.54 to 2.26 per 1,000 occupied bed days. Another study used a retrospective cohort design reviewing existing data across 5 hospitals before and after remote video monitoring. The researchers found a decrease in fall rates and also reported mortality decreasing from 7% to 1%. Finally, the last study used a quasi-experimental controlled pre- and post-intervention design. Researchers implemented remote patient monitoring and compared outcomes before and after implementation, while also including hospitals that did not use the intervention. Because there was no random assignment, the study was considered quasi-experimental rather than randomized controlled trial. In the remote patient monitoring hospitals, total falls decreased by 33.7% from 175 to 116. Falls among high-risk patients decreased from 120 to 78, and the high-risk fall rate decreased from 3.11 to 1.83 per 1,000 patient days. Overall, despite differences in study design, the findings consistently supported video or remote patient monitoring as an effective intervention for reducing inpatient falls.
Hi, my name is Michelle, and I will be going over the limitations of our studies. So there were several limitations within the studies that we reviewed. One of the biggest limitations was that none of the 5 studies were randomized controlled trials. Instead, they were primarily used prospective or retrospective cohort designs, along with one quasi-experimental design. And because patients were not randomly assigned, there was a greater potential for bias, and it makes it harder to determine whether video monitoring itself was responsible for the reduction in falls. Another limitation was the variation in sample sizes and patient population. Not every study focused specifically on geriatric patients, even though that was the population of interest in our PICO question. Some of the studies included hospitalized adults of all different ages, so the findings may not fully represent the geriatric population. We also found differences in how video monitoring was used and how falls were measured between the studies. Some studies relied on retrospective data or staff-reported fall incidents, which can also increase the possibility of reporting bias. The studies also conducted were in different hospital settings, with different in staffing, patient populations, monitoring procedures, and existing fall prevention practices. These differences could have influenced the results as well. Even with the limitations, the studies consistently showed a reduction in inpatient falls after the video monitoring was implemented. However, we can't really definitively say that video monitoring alone caused that reduction. Overall, the findings are still promising though, but more randomized controlled trials using larger geriatric populations, true control groups, and more standardized interventions are needed to provide stronger evidence.
Hello, this is Bonnie Andrews for the conclusion. So the big takeaway for us is that video monitoring looks like a promising addition to fall prevention, especially for older adults who are at higher risk. It's not meant to replace nurses or other safety measures, but it can give staff another set of eyes on patients while potentially using resources more efficiently. Going forward, more research will help us understand where and how it works best. Thanks for listening.